Welcome back, everyone. I'm really excited to introduce our next speaker, Dr. Robert Sheeler. Um, he is a family medicine physician who practices integrative and functional medicine in Scottsdale, Arizona. He received chemistry and biology degrees with honors from Grinnell College in Iowa, and then attended University of California at San Diego for medical school. He practiced at Mayo Clinic for over 20 years, during which time he was the clinical practice chair for the Department of Family Medicine, chair of the Neuropsychiatric Medicine Group, and medical editor of the Mayo Clinic Health Letter, in addition to being the clerk chair in family medicine and teaching pharmacology at Mayo Medical School, where he was an associate professor. Very busy individual. Dr. Sheeler also has a wide variety of interests, including Qigong and the study of a variety of mind-body practices. And he is certified as a headache subspecialist by the United Council of Neurologic Subspecialties, as well as being certified in functional medicine by IFM. He's also been board certified in integrative medicine. We're very lucky to have the chance to work with Dr. Sheeler. He serves as chair of the Emerson Ecologics Medical Advisory Board, and right now also practices as a full-time clinician. So he has a lot to share about how you can really gain functionally oriented information from labs that you likely order or see all the time already, but maybe aren't maximizing the interpretation of. So today he's going to cover how much you can learn from a simple CMP, comprehensive metabolic panel. So trust me, this is next level compared to what you learned in medical school. I guarantee it. So Dr. Sheeler, I'll let you go ahead and take the mic.
Well, thank you very kindly. I'm delighted to be here, and chemistry and biology are two of my first loves. Both chemistry and biology have been around before the caveman, but our understanding of them is a lot more recent than that. And so I studied both chemistry and biology undergraduate, and both of those were just passionate for me. I really loved learning them. And in medical school, I went to medical school at the University of California, San Diego, which was a very molecular school. As a matter of fact, it was so molecular that there was someone in my medical school class had their undergraduate biology degree from UCSD, and they didn't know the difference between a vertebrate and an invertebrate because all of their training was at the molecular level. And so I really love biochemical pathways. That's one of the reasons I like functional medicine, but I also like the integrative approach where we look at the whole person. And by being Oslerian, by looking at things that really tie things together, we can see how different things relate. And the results of a chemistry panel are one way to do that. So I want to talk from the chemistry evaluation standpoint, but also from the standpoint of pathophysiology, because in the second year of medical school was my absolute favorite course in pathophysiology, where we learned about root causes. And it seems to me that something has gotten lost along the way, is that we learn this, it's our passion, we understand it, and then you get to the third year of medical school and into the clinic, and it's treat this with that, treat that with this, treat this with that. Oh, this doesn't work, add that. And we get away from root cause medicine, which is why I really like going back to functional and integrative medicine to look at those root causes. And the chemistry panel will give us some insights into that. So I like to liken some of this study to Dickens' Christmas Carol, one of my favorite Christmas stories, and think about the ghost of Christmas past, like what you knew during your medical training, and those synapses are still there, but they're not very active, but they can be reactivated. What you know now and what your current practice of medicine and understanding is like, and then what you might enjoy knowing, some just from further study and deeper study that we're going to do a little bit today, and some from the evolving personal precision medicine that's coming into medical practice that will, as AI advances and as tools become more cost effective, will be incorporated into the skill set and into the resources that all of us have. And this is happening from the standpoint of each of us as an individual, but it's also happening from the standpoint of medicine as a practice. And so the traditions, what traditional medicine, what traditional cultures knew, what we know now, what the current understanding is, and how our biologic, chemical, and clinical knowledge are evolving. So think of some of this as reactivating old synapses, some of it as saying, I know that, and feeling good about it, and some of it of thinking about how will this fit in with my practice in the future. So First, I want to talk about glucose. Glucose is a universal molecule in our body, and most of glucose comes from fructose and glucose together as sucrose when it's broken down. Glucose, everybody in the body likes. The muscles like it, the brain loves it, the heart likes it, the kidneys like it, but fructose, not so much. It more goes through the liver. So lab normal for glucose, most places is 60 to 100. Optimal is sort of 80 to 83 to 90 to 93, because if you get too much lower than that, you may not be getting optimal function all the time. And as you start to get above those numbers, you will end up getting insulin resistance and starting to cause systemic inflammation. So I want to talk to you about a patient who came to see me. They were going to a major medical institution here in town. They've been going there for their checkups for years, and they were told, yep, everything's fine, you're good. Maybe your sugar's a little high, but really don't worry about it. And so I looked back at their chart over the last 10 years, and when I saw them, their blood sugar was 127. But what I looked back at before was their sugar was 98, then it was 101, then it was 102, then it was 104, 106, 117, 18, 20, 21, 25. And all that time, they were told their sugar was normal. And then lo and behold, it was 127 on 2 occasions. And they said, my goodness, I was bit by the diabetes bug. Who knew? Who could have told that I was going to get diabetes? And all of us in root cause medicine practice would say this is something that's been going on for a long time. And as your glycohemoglobin creeps up and your glycosylating proteins that are on nerve fibers and blood vessels, not just inside your red blood cells on the hemoglobin, you will be getting closer and closer to diabetes. And so I like to look a lot at glycohemoglobin, which is the area under the curve. And so your fasting sugar is the relationship between your gluconeogenesis, how much sugar you make, and your insulin response in relation to meals. It's also in response to that how high glycemic your diet is, what your microbiome is, and how that processes your sugar, and then other non-insulin dependent mechanisms. And so, for instance, one of the Qigong phrases that I learned from my Tai Chi Qigong master is, the person who walks 1,000 steps after every meal will live to be 99. And I thought, well, that's cute. And then just after I learned that, a year or so later, out came a study that shows that people who walk after every meal have a lower glycemic load, and their overall blood sugar and A1C is lower. And the reason is that skeletal muscle is responsible for 70% of our sugar metabolism. And so if you're using muscle to get sugar out of the bloodstream by a mechanism that's not dependent on insulin, 1, you don't need as much insulin, and 2, the insulin you have is more available to drive down that sugar. And so I want to look at some different patterns of sugar, because sugar is one of the main things that I look for on a complete metabolic panel, and it's one of the main drivers of cardiovascular disease, of cognitive decline, of visceral adiposity, or VAT, which is the fat around the middle, which is also fat around your liver and your internal organs. And so this is an interesting phenomenon. So it's easiest to measure glycosylation by checking the hemoglobin and see how many sugar molecules are stuck onto that. And red blood cells live for 2 or 3 months, and then they're recycled for parts, because the heme molecule and the iron are valuable to the body, and we don't really want to lose those. And so, how does that relate to, what we want to learn and how we understand sugar metabolism from the standpoint of glycohemoglobin? So I'm going to ask you a question that one of my functional medicine friends taught me, and he said, can glycohemoglobin ever go up if a person gets healthier? And I thought, well, that doesn't make any sense. Why would your glycohemoglobin go up? And he'd had several patients who their glycohemoglobin went up after they started taking supplements that would lower their sugar, after they started taking antioxidants, after they ate a more anti-inflammatory Mediterranean type diet. And the patient came in and said, well, all the stuff you're doing for me isn't working. My glycohemoglobin went up. And so I got to thinking, based on my discussions with him, how could this happen? And he had the same conclusion, is what can happen in a healthier environment is that if you have a lot of oxidative stress in your body and you have oxidative damage, then your red blood cells don't live as long. And so if your red blood cells are constantly bombarded by oxidants, then they might live closer to 2 months instead of 3 months. And the glycohemoglobin is a measure of how many sugars are stuck onto that, which is a metabolic enzymatic process that happens bit by bit over time. So if a red cell is around for 3 months, it might have more red blood cells on it than if it's around, it might have more glycosylation. And so if you damage your red blood cells and take them out of circulation faster, then they don't have as much time to build up the glycosylation. So actually, if you are healthier in a certain circumstance, if you're starting out in a very high oxidative stress situation, and then you fix that and your red cells live longer, there can be a transient period where your glycohemoglobin actually goes up. And so how would I tell that this is happening in some of my patients? Well, I would probably look at markers of oxidative stress, like oxidized LDL and 8-deoxyguanosine. And so those are fairly standard measures of how much oxidative stress a person's getting. And I think that they can be valuable in assessing the person's overall status. So here are the different patterns that I look for between glucose and A1C. If your fasting glucose is normal and your A1C is normal, then that means that the fasting glucose is a balance between your gluconeogenesis overnight and your basal insulin secretion. So think of that as the adequacy of your basal insulin secretion. Your hemoglobin A1C is normal is your stimulated insulin secretion. Can the insulin do the job for the type of diet that you have and your level of receptor resistance and receptor status? Then if your fasting is elevated and your glycohemoglobin is normal, then that means that your basal insulin secretion may not be quite high enough, but once you're stimulated with food, you put out plenty of insulin, and so your overall area under the curve, the average, is better. And that's probably a better state than the next one, which is normal fasting sugar, which is normal basal insulin secretion in relation to your gluconeogenesis, and elevated A1C. So why would the third one be worse than the second one? Well, if A1C is the area under the curve, A1C is the number of glycosylated end products that are getting attached to your nerve fibers and your brain cells and your heart muscle and your vascular endothelium. And so it's better to have a somewhat elevated, like 102, 103 sugar in the morning and a glycohemoglobin of 5.4 than it is to have a fasting sugar of 99 and a glycohemoglobin of 5.8. And then when we get into frank diabetes, or at least prediabetes, you get an elevated fasting sugar and an elevated glycohemoglobin. So I like to explain all these to my patients rather than just leave them as a mystery. It's like, well, you said my sugar was normal, but it's not normal because your A1C is normal. Okay, but how come my sugar is normal? So those are two separate but related phenomena. Okay, so here's another question for you. What goes up 20 years before the diabetes diagnosis, typically? And so this is something that I measure routinely in my patient, and that is fasting insulin. So fasting insulin may go up 20 years before you show up with diabetes, before you're bit by the diabetes bug. So ideal is about 4 to 7. And if it is significantly lower than 4, then you may either be hypoglycemic a lot of the time because you're dieting or you're doing keto diets, or, in which case, if you have good metabolic flexibility, that's probably okay because your body can switch back and forth and burn ketones for fuel. And that's the best status, is where you can go back and forth and burn with great facility both ketones and sugar. But a lot of people who are dieting too heavily, they get their sugar too low. And we're going to talk about that a little further as well. And so ideal is about 4 to 7, mildly elevated 9 to 11. So if somebody comes in and their sugars are otherwise fine, their fasting is normal at 90 and their A1C is 5.6, but their fasting insulin is 11, I think this person's going the wrong direction. And then we see a number of people in the 12 to 19 range, and then lab normal, depending on the lab, is 20 or 25 or over. But for me, that's way too late for how I want to treat people, because I have a lot of people come to my office and they are otherwise healthy. Maybe their carotids are completely clear. Maybe their coronary scans are negative, but they've got family history of problems. And I say, what I want to do is, you're not in immediate peril, but what I want to do is I want to say there's an iceberg ahead of your ship. And if we are far away from that iceberg and we just correct the course 2 or 3 degrees, we're going to miss that. And we're going to steer you to a higher level of health. So I like to look for things that show up years ahead rather than when you're behind. And the same is true in the way we look at vascular disease. We look at advanced lipid markers and other things like that because we want to find them before rather than just when a treadmill test will show, oh, your arteries are 60% blocked. Now we care about you. So we don't want to treat the disease entity. We want to prevent the disease entity and treat the patient. So here's the flip side of this is, what do you think of if your fasting sugar and your A1C are both elevated, but your fasting insulin is low? Well, what I think of in that situation is you're hyperglycemic, you have long-term sugar elevation, but you don't have enough insulin. So that's probably your pancreas failing. So that could be adult onset type 1 diabetes, or it could be another situation like pancreatitis or things where you're not able to produce enough insulin, and that's why your FBS and A1C are elevated despite a low insulin. So that's kind of a bad situation because a lot of the medicines we have will drive your insulin up or change insulin sensitivity. So if you don't have enough insulin around, that's going to be a problem. So this is kind of the inverse, just like sometimes the thyroid testing is the inverse. So in thyroid testing, which I used to teach a lot of board review courses on, you remember that most thyroid disease is at the level of the thyroid gland. And so an elevated TSH means the brain is shouting, hey, make more thyroid. And a low TSH means the brain saying we've got enough or too much thyroid, don't make any more. But if it's at the level of the brain, then your TSH won't be produced if you've had a stroke in that area, or you have a brain tumor, or you had previous brain surgery and they cut out that part of your pituitary, then your TSH will be low. So this is that same kind of situation. It's the inverse, is that a low fasting insulin for this person is actually a more ominous sign. So supplements of value for elevated sugar. There are 2 nutritional supplements that I use a lot for elevated sugar. One is berberine and one is bitter melon. And bitter melon is not as strong as berberine, but I like the mechanism of action. And so we're going to talk a little bit about that. So I've been designing supplements for the last few years, and sometimes it's nice to use things together that have different mechanisms of action. So berberine versus statins. And so a lot of people will use berberine for high cholesterol as well as high sugar. So berberine will lower cholesterol, and statins will lower cholesterol. Statins will lower it dramatically sometimes. And actually, statins sometimes lower it enough that I'm concerned, because cholesterol is the ring structure precursor to all your hormones. And it's also key for membrane structure in your body, for the cell membrane integrity, and also for myelination in the nervous system. So I think we do need some fats. And I disagree with some of the cardiologists who say, a total cholesterol of 70 and an LDL of 30 is ideal. It's like, I don't think so. I think you need some cholesterol. And I like to sort of default to the fact that, the body has things in place for a reason, and we may grossly distort them by our diet and nutritional choices. But once we optimize those, then some of these molecules have value. And then berberine will lower your glucose, and most statins will raise your glucose. So I believe that statins do that through effective damaging mitochondria over time. Now, statins are associated with longevity. Statins will help you get beta amyloid out of your brain cells. Statins will stabilize unstable plaque. So I certainly use them, but I'm cautious. And there is one statin that, at least for most people, doesn't raise sugar. And that's one that still has a patent in the US, but I believe it's gone in Canada, called pitavastatin or Livalo. And so, but most statins over time will raise glucose. And so I was visiting a physiology lab, and they showed me all of their wonderful results on blood vessel effects and blood sugar and improved conditioning and better cardiovascular status. But the cardiologist who ran it put everybody on statins, as many cardiologists are wont to do. And I looked at some of their charts over 10 years, and their glucoses went from 97 to 128. And so I think that's a statin effect. And there are programs around the country, like the Bale-Donine Cardiac Reversal Program, that treats small and large vessel diseases and has reverse plaque in some people, that they use statins in microdoses. And so their joke is you just nibble on the statin, you actually don't take it. And so statins at low dose have significant anti-inflammatory effects rather than just sort of brute force lowering the cholesterol. The microbiome effects, berberine is used to potentially favorably improve the microbiome and kill off some pathogens. And statins, to my knowledge, don't have a really specific microbiome effect. And both statins and berberine have positive effects on endothelial function. And endothelial function is almost as close as we can get to root cause medicine for the cardiovascular system. So I do use some other supplements, things that help arterial health and rebuild the glycocalyx that will really improve vascular elasticity and vascular responsiveness at the microvascular level. And I've had reversals in hypertension. I've had people have their microalbumin area improve and things like that. So this is the next thing I want to talk to you about. It's called the Asian paradox. And so this is white rice, which most of us who favor low glycemic diets would say, oh, white rice is evil, is bad, don't eat white rice, it's bad for you. And so we started telling our Asian friends, oh, eat brown rice instead of white rice. White rice is bad for you. You shouldn't eat white rice. And they go, okay, look in the mirror, dude. You guys are heavier, you have higher cholesterol, you have higher blood sugar, you have more diabetes, you have more cardiovascular disease, and you're telling us what to eat? It doesn't make any sense. And so there are a number of explanations for this. One of them might relate to lectins that may still be present in brown rice and things like that. But most of it is the glycemic effect of white rice is not nearly as significant in the overall Asian diet as it is in the American diet. And the reason is like dynamite. And so you think, what does dynamite have to do with white rice? Well, if you take a stick of dynamite, or in this case, 7 sticks of dynamite, and you throw them on a campfire, you know what's likely to happen? Some of you are probably thinking, boom. It's like, no, it will burn. It will just burn up in the fire most of the time. And the reason is it needs a blasting cap to make it go off. And that same thing is true for simple carbs. So this is our culprit molecule. This is fructose. And so fructose, I believe, at high doses is a metabolic poison. We talked about sucrose and glucose together. Sucrose is glucose plus fructose. So if you take in a high sugar diet, half of it is glucose that everybody likes. The heart likes it, the muscles like it, the kidneys like it, and the liver likes it. But only the liver can really metabolize fructose. And once it gets to a certain level, and that level is around 40 or 50 grams a day, some of it has to go through other pathways. Some of those other pathways cause insulin resistance and inflammation and fatty liver and other changes like that. And so these are umbrioche plums. And the reason that I bring them forward to you at the moment is I spent one time a week and a half in Japan at a headache conference, and I had a wonderful Japanese guide, and he took me all over. He and his significant other took me all over Japan to little temples and to restaurants and other places. And one time I said, wow, I really would be excited about some dessert. Like I could really go for some like French chocolate. He said, yeah, I've had French chocolate, but I have something that's even better I want to share with you. And I said, oh, great. So let's go and have what you suggest. And what it was a salted umbrioche plum. And it was sort of bitter and sort of salty and maybe a little sweet, but hardly at all. And so I got to thinking, okay, so that's what these guys eat. And I was actually walking 10 miles a day during my time there and really enjoying my time. And I think I might have found a popsicle or something later at one of the quick convenience stores because I was still hungry, and their meals were suited for maintaining trimness. And so I found out that those folks were eating 40 to 50 grams a day of sugar or less, and we eat way more than that. And so we've started to introduce things like coffee chains and fast food restaurants that will have a milkshake that has 80 grams of sugar in it, or a triple latte that has 120 grams of sugar in it. And we blast them beyond that 40 to 50 gram threshold. And so now the incidence of obesity, of hypertension, of diabetes, of cardiovascular disease is greatly increasing in other places around the world that have adopted our diet. And I think it's that threshold of 40 to 50 grams of sugar that has been passed that does it. And so I've taught my patients, after I've taught myself, to look at the labels on everything and to learn how much sugar everything has. And if you can stay under that level, then you don't have a blasting cap on your dynamite and you can have some simple carbs. Uric acid is another interesting molecule. Uric acid is inflammatory in nature. Not only can it cause gout, but it's related to glucose metabolism and metabolic dysfunction. And so at levels over 6, the risk of gout increases. If you have severe problems with gout, such as tophi or renal disease of any kind, or uric acid stones, then you probably want your level under 5. Now, here's another interesting thing that I learned once I started studying the functional aspects of chemistry. So lactate dehydrogenase, LDH, we mostly used to use that. It was a marker of cardiac damage before we had CK, before we had troponin, and we would use it for that. And then we try to differentiate it with isoenzymes between the cardiac fraction and the liver fraction and the muscle fraction or other undifferentiated special tumor fractions. But what I learned in functional medicine and by studying functional chemistry is if somebody's LDH is under 140, that often means that they're getting hypoglycemic a lot of the time. And so I have started including this on protocols that I design, and in my patient care, I will check this frequently to see if people are maintaining good glycohemoglobins, but they're actually starving themselves some of the time, and they're getting suboptimal performance and suboptimal metabolic support for enzymes and processes throughout the body. So this I found helpful when I'm looking at sugar metabolism. So here's an electrolyte and chemistry pattern I want you to look at with me. So sodium 122, mildly hyponatremic, potassium 5.2, upper limits of normal or mild hyperkalemia, slightly low chloride, CO2 16. Most labs will have 20 as a normal for CO2. So as you have lower CO2, you're getting acidotic, and a glucose of 512. So why would this person be hyponatremic and hypochloremic as well as have an acidosis? Well, this is diabetic ketoacidosis. And the reason their sodium is diluted is because they have so much glucose that that's changed the osmolality of their serum. Potassium actually goes up for other more complicated pump reasons. Chloride goes down for the same reason that sodium does. And CO2 goes down because the person has a metabolic acidosis. So this may be part of your ghost of medical studies past, the anion gap. And some of my hospital friends use this all the time. An anion gap of more than 10 is abnormal. And as you will recall, either from previous practice, current practice, or nightmares, the anion gap is equal to sodium minus chloride plus CO2. And so in this last patient, their anion gap was 14, and an anion gap over 10 is abnormal. And why is that of use, or why do we care about that? Well, we care about it because anion gap and non-anion gap acidoses are different things. And so salicylates and aspirin, ethylene glycol and ethanol, lactic acidosis is a big one, iron overdose, acetaminophen excess, and in this case, diabetic ketoacidosis, uremia, and carbon monoxide poisoning all cause acidosis with an anion gap, whereas non-anion gap happen in chronic kidney disease, which can sometimes lead to type 4 renal tubular acidosis, metabolic renal tubular acidosis, diarrhea, and volume loss, and then hyperaldosteronism are common causes of non-anion gap acidosis. And so we can not only use the chemistry panel itself, but we can use values that we derive from that. So this is something called de-Ritz ratio. And I remember this from medicine, and I've had some patients recently with abnormal liver function tests. And so I've started to use this more. So if de-Ritz ratio, if the AST to ALT ratio is less than 1, what does that usually mean? Well, this was discovered 50 years ago by de-Ritz, and that if the AST to ALT is less than 1, that's often seen in acute viral hepatitis. Whereas alcoholic liver disease usually has AST greater than ALT, so that ratio would be greater than 1, usually greater than 1.3. It also can be used more definitively early in hepatitis because AST has a half-life of 18 hours and ALT has a half-life of 36 hours. So that can be predictive of the course of whether things are rising or falling in an early hepatitis. But for larger prediction in our population, both NAFLD, non-alcoholic fatty liver disease, and alcoholic liver disease, if the AST is greater than the ALT, so that ratio would be greater than 1, that's predictive of liver fibrosis and progression to liver cirrhosis. And so just that simple ratio, knowing that ALT is more liver specific, but AST shows up more in chronic damage, is helpful to know something about the status of your patient. When I look for patients who have alcohol problems, I also look at their proteins, and we're going to talk about that in a bit. And then I look for low platelets and high MCV. So even if your folate and your B12 are normal, I used to think that all of alcohol damage was related in blood indices to nutritional deficiencies, but actually some of it is direct toxicity on the bone marrow that will cause macrocytosis. And so what vitamin may help prevent NAFLD? Well, there's actually good research in the last year that shows that vitamin C will do that. And a dose of about 1,000 milligrams a day has a good effect. As always, if you can get 1,000 milligrams a day from fruits and vegetables, then you're probably better off. But most of us would have trouble doing that. And so 1,000 milligrams a day of a good vitamin C is a reasonable thing to do to help prevent NAFLD. Vitamin C also, interestingly, lowers uric acid. And so it has a number of beneficial effects. Okay, so this is back from my medical school days. When I was in medical school, they used to use the med students as normative values for the lab. And so I don't think we got a choice in it. It was like, I don't think we were prisoners, but they didn't tell us we had a choice. And I don't think anybody was a conscientious objector. But since some of the people didn't really want to do that, what they would do is they would go out the day before and run like 5 miles if they're used to only walking a mile. And their AST, which is from muscle, would go way up, and their ALT, which is not in muscle, would stay normal. So maybe they got thrown out of the lab normal pool, or maybe they skewed it. But if you see an AST very high and an ALT totally normal, think about skeletal muscle as another source from where that can happen. And so what's the possible significance of a low AST and a low ALT? So let's say your AST is 4 and your ALT is 6. Well, actually, that can happen if your vitamin B6 is low. And so I learned this in medical school. We had a professor named Professor Wolf, and everybody wanted to take his course during the senior year of medical school because he would take you on deep dives of labs. And so we would go around and make what was called the wolf pack rounds, because we'd be the wolf pack and we'd go in and look at charts and try to understand what person had looking at their labs first and then reading their chart afterwards. And so this is one thing that he taught me before, and then I relearned in my functional medicine studies. And I have seen this a number of times in the last couple of years as well. Okay, so when bilirubin is elevated and is persistently elevated and the person has Gilbert's disease, they say, oh, that's a benign disease. It's, the textbooks say it's of no consequence. But in functional medicine, I'm not sure we really believe that, because Gilbert's has to do with glucuronidation. And there are 5 main detoxification pathways in the body that the body makes things soluble and gets rid of them with. And glucuronidation, along with this acetylation and methylation and sulfonation, are some of the main ways the body gets rid of toxins. So if one of those detox pathways is down, or at least partly impaired, you may not do as well. Okay, so what's a typical pattern of liver function tests in cholestasis, where you have either a tumor or a stone or something else, or pancreatitis blocking off the outlet of the liver? So if we look at AST, the transaminases are mildly up. GGT has a deeper ductal component, and that's elevated, but it can also elevate with significant alcohol intake. However, it's not always acute. I had someone who had like 20 drinks one New Year's Eve, and they had to come in for their insurance physical on the 2nd of January, and their GGT was totally normal. Alkaline phosphatase is up significantly, and then bilirubin is up significantly as well when you block off your duct. So obstructive jaundice is mostly conjugated bilirubin. So the liver has already done its job conjugating bilirubin, making it more water soluble, and unconjugated bilirubin is more pre-liver processing, whereas conjugated is the one that's excreted in the bile. So what would you think of a COVID patient with an elevated unconjugated bilirubin? One of my patients, who's another doctor, got COVID last year, and his unconjugated bilirubin was like 3 or 4. And it turned out he was also anemic. And so what he had from COVID was a hemolytic anemia. And it went away when his COVID resolved, but it was actually kind of scary. Whether that was autoimmune or direct relation to the infection, I'm not sure. We do a lot of genomics in our practice, and we often will test people's G6PD pathways. And so you may remember that the food that's famous for that is the same food that Hannibal Lecter made famous. This fava beans are the main food source of activating that, but a number of drugs will do it. Most of them we don't use much, but one class of drugs will cause hemolytic anemia in patients with G6PD. And I won't tell you what it is. No, I will tell you what it is, but it rhymes with alone. So quinolones. So quinolones will cause hemolytic anemia in patients with G6PD. And there's a number of patients in the population who have this. What else other than liver disease can elevate alkaline phosphatase, and what causes low alkaline phosphatase? Well, the thing other than liver disease is mostly bone disease. So it could be bone tumors, and it could be metastatic disease to the bones, but it also could be things like Paget's disease of the bone, or even severe osteoporosis will do that. And I've had people that I had to treat with a bisphosphonate plus estrogen to get their alkaline phosphatase back in the normal range and their markers of bone destruction in the urine down. And what causes low alkaline phosphatase? Well, there are certainly some specific genetic syndromes that do, but the first thing I think of is zinc deficiency. And so just like B6 can be low when your AST and ALT is low, if your alk phos is low on the chem panel, think of, is this person deficient in zinc? So what other diseases should you think of when you see elevated transaminases? And I will tell a person to eat a healthier diet and to not drink as much alcohol. And I'll check them for hepatitis B and C and make sure they don't have an acute hepatitis or a chronic CMV infection. But if it's not infectious, what other kinds of things should you think of for elevated transaminases? Well, you should think of sarcoid and check an ACE level. You should think of alpha-1 antitrypsin, and there's a society that will do free genetic testing for alpha-1 antitrypsin. We have a bunch of their free kits in our office. NASH, non-alcoholic steatohepatitis, can cause that, and that's getting to be a cause that's actually competing with and may even pass up alcoholic hepatitis. And so it's important to determine if somebody has NASH. And so an ultrasound or a CT may show fat, but there are also studies such as MR elastography and other indices of the liver that show the liver is getting stiff, and that's a problem. Another disease to think of is hemochromatosis. And so if your iron is elevated and your ferritin's elevated, that should be considered as well. And then autoimmune hepatitis. Some is related to inflammatory bowel disease, and some is just autoimmune of itself. It may have positive ANA, positive microsomal, or mitochondrial antibodies. And so what's the difference, likely disease states between these two patients? Patient 1, their ferritin's 800, and their iron or iron binding is 57%. And patient 2, their ferritin's 450 with a normal iron binding. So ferritin is also an inflammatory marker, and some labs will even say 350, 380, 450 is normal, but I think an ideal ferritin is between 50 and 80. So ferritin 800 is way up, and anytime your FETIBC is over 45, 46%, you should start thinking of hemochromatosis. So the first patient has a high likelihood of having hemochromatosis, and the second person with a normal iron binding and elevated ferritin, I'd look for other elevated inflammatory markers like HSCRP and try to determine if that person had liver disease as the cause of that rather than hemochromatosis. So looking at the following, what could be learned from the following chemistry panel results? Normal albumin, normal sodium, potassium, AST, ALT low, bilirubin low normal, alkaline phosphatase normal. Well, this is that pattern we just talked about. This is one that could be vitamin B6 deficiency. And then another thing that I will often do when I'm trying to decide if somebody has chronic liver disease and if they're a drinker or if I should go further looking for causes of liver problems is I check a serum protein electrophoresis. So we're all familiar with that, looking for myeloma and monoclonal gammopathies. But what you actually see with liver disease is a broadband elevation of multiple gamma fractions called a polyclonal gammopathy. So their gamma will be elevated, but it's not a spike. it's a broad-based peak. And so that's something I look to see if I'm really trying to decide, is this just somebody who's been drinking a little too much because they spent the last month in Las Vegas, or is this somebody who's got a more chronic problem and there's more stuff going on with their liver that I need to investigate? So I would argue that in addition to ProTime and PTT, which are looking for synthetic functions of the liver, as does albumin, I would check a serum protein electrophoresis as well. Okay, what condition can present with any of these issues and how do you test for it? Anemia, diarrhea, headaches, depression, and Hashimoto's. Celiac disease. So the standard testing for celiac is TTG IgG, TTG IgA, and a serum IgA level, because unfortunately more celiac patients actually have an IgA deficiency. So if you just tested IgA, which is the most sensitive and specific, but the person had an IgA deficiency, you'd miss it. Whipple's disease can also share a lot of these presenting issues, but one of the things I've found in my functional medicine practice is people will show up with non-GI manifestations of celiac disease. And so I've had a number of people whose migraines I cured completely with this, people whose depression went away, people whose neuroinflammation went away. And so always be thinking of celiac disease. And that's one thing I like about being in private practice. The patient might have to pay for the test, but I don't have to sit down with my department chair and explain once a year why I'm ordering so many celiac tests when only 1% of the population has it. The reason is because finding that can be life-saving and can be life-changing for patients and really improve their quality of life. So I think that disease is worth looking for, even though only 1 or 2% of the population has it. What can cause significantly elevated amylase with a normal lipase? Macroamylasemia. So there are things where amylase aggregates and doesn't get excreted in the urine, but it's not a disease. And what type of patient is most likely to have significant renal dysfunction with a normal creatinine? And what's another test that will pick that up? Well, as people get older, they lose their muscle mass. So if you're sarcopenic, that's where creatinine comes from. If you have no muscle, you're not going to excrete creatinine because you don't have very much. So you can have a normal baseline creatinine and still have abnormal renal function. So I like to look for cystatin C when that happens, because that's a good alternate test. And then what might cause this pattern in a patient with heart failure? Creatinine 1, BUN 40. So that your BUN to creatinine ratio, when it gets over 20, signifies intravascular volume depletion. So usually that's diuretics. And sometimes we run it up to 80 or 100 to get the person dry enough to get the fluid out of their lungs. But what else can elevate BUN significantly without raising creatinine or cystatin C? GI bleeding can do that. So if you have a GI bleed, your BUN can go up dramatically because you're dumping a bunch of urea nitrogen into your system, and then you reabsorb it. And then finally, what's the most common cause of this pattern of chemistry results? Potassium 5.9, creatinine 4.0, BUN 60, 125 hydroxy vitamin D level low, phosphorus high, cystatin C high, calcium low. Well, this is chronic renal dysfunction. So if the potassium was high from like an adrenal cause, so let's just say you had Addison's or hypoaldosteronism, your creatinine wouldn't be 4, your BUN wouldn't be 60. And then vitamin D is converted from the 25 hydroxy dietary form to the 125 active form by renal or juxtarenal tissues. And so when you get renal failure, you don't do that. And that's one of the things that we give patients in renal failure. Phosphorus is hard to excrete, just like potassium is hard to excrete, so it's high. Cystatin C is high, just like creatinine, because you actually have renal failure. And your calcium is low because you get a secondary hyperparathyroidism. So that's been my brief rush through the chemistry panel, showing you lots of the things that I like to play with and see and sort out. And it's a little bit like being Sherlock Holmes instead of Dr. Watson. We'll turn it back over to Jacqueline and take any questions you all might have.
Wonderful. Thank you so much, Dr. Bob. This was amazing. And it was great to go through some of the reminders and learning some more clinical pearls from the kind of the basic chem panel. So thank you so much. Just a couple of questions that came in through the Q&A. Can you repeat the fasting, I think they meant fasting insulin and A1C chart? They just missed a couple of the options available. Maybe we can go back to that slide there towards the beginning. And while we're pulling that up, what was the name of the less bad statin that you mentioned? I think it was available just in Canada.
It's available here, but it's a brand name, so it's expensive. It's called
Oh, I see.
Livalo, Livalo is the brand name, and Pitivistatin, Pitivistatin, is the generic name.
Okay, wonderful. Thank you so much. And here's the glucose A1C patterns that were noted there as well.
Right. So both normal, you're in great land. Both elevated, you're either well into prediabetes or diabetic. And then fasting elevated with a normal A1C means that your basal insulin secretion in relation to your gluconeogenesis in relation to your basal insulin secretion is out of whack, and so you don't secrete enough basal insulin. But when you're stimulated by food, it drives it down normally. And then when the fasting is normal, it means your basal insulin secretion is fine. But when you eat food, or at least the food that you choose to eat in your circumstance, it's more than your insulin secretory capacity. And so then you have an elevated A1C despite a normal fasting sugar. And that's why I like to take a lot of these things. I like fasting insulin plus fasting glucose plus A1C all together to give me a better indication of what your glucose metabolism is.
Excellent. And can you also repeat the reasoning that you see low transaminases?
Yeah, the main reason that we see the low transaminases that I've been taught is that that can be a vitamin B6 deficiency. I don't know the exact molecular mechanism of that, but I know that that B6, I think, is an important cofactor for transaminases. And so I've been taught, and when I've checked it, when I've checked B6 levels, it has panned out that those low transaminases often indicate B6 deficiency.
Wonderful. Thank you. And someone asked, I missed the introduction. Does he have a book? How can I learn more from Dr. Sheeler? So, no book at this time on lab interpretation, but if you want to learn more, he does teach a lot for us. So, pay attention to Emerson. One of our most popular webinars Dr. Sheeler teaches, which is Supplements 101, going through really like the top 10 supplements that every practitioner should be utilizing in practice. And I bet there's some on there that would probably be a surprise to you. So, it's worth definitely checking that out. Any other great resources or references that people should go to learn more about this kind of thing?
No, I mostly learn things by looking them up one at a time, as well as when I read other articles or when I read about specific tests. You can often read good chemistry textbooks. You can read good individual articles that you find in PubMed searches, and they will go through the differential diagnosis. And so I will look for things that give me a differential diagnosis of something, and then I'll try to determine whether they're relevant to my practice and whether they're just very rare one-offs.
Wonderful.